Start. Perfect. Thanks. Welcome everyone to February Health in Hackney. Just a few matters of housekeeping, if I can. My name's Councillor Hayhurst. I'm the chair of this meeting. This is a formal council meeting. It's being live streamed. It's being recorded. Members of the press are normally watching. Please, can everybody keep your microphones on mute unless you're speaking? Can commission members please keep your cameras on? If you'd like to speak, either raise your hand, your virtual hand, or make a brief comment in the chat function. But please don't otherwise start conversations in the chat other than just to say if there's a question or not. I haven't been notified of any declarations of interest. Nor apologies of absence. But before we just go on to the substantive item, two thank yous. It's been mentioned and also thanked in other places, but David Maher, you're off to be Deputy Chief Exec in Northamptonshire Healthcare NHS Trust. You've led the CCG to an outstanding status, a brilliant CCG. You've overseen the Homerton becoming an outstanding hospital. We're very proud of the CCG you've overseen. Thank you very much indeed for your efforts, your collaboration with us over the years, and you're going to be sorely missed. So thank you. And can I also take the opportunity to thank Denise D'Souza as well, who's our interim group adults director, who's also leaving us at the end of March. I think you came to us from Brighton over the last year, Denise, and you've been a great help in terms of letting Anne Canning move over to Children's. Thank you very much, and thank you also for staying on for an extra period as well, which I know you weren't going to do, so as to enable a smooth transition for the permanent person for the role. So thank you, Denise. Thank you for your work during this very hard time over COVID. So with those, can I go to straight into item 4 on the agenda, which is an update on where we are with the vaccination rollout. Now I'm having a quick look as to whether Laura has joined us.
Laura can't get in. She says she can't get in. I don't know if someone can send her the link or something. She's trying to get in, but she can't.
We're trying. Bear with us.
Fine. Okay. Siobhan Harper. While I'll give it a second, because I know the plan was for this item for Laura to kick off and then just go to Dr. Millar, who's was just speaking just then. If we can't let Laura in, it may be that I ask Dr. Millar to show us her slide first. But let's just see if we can get Laura in first.
Can I just clarify? I'm not Dr. Millar. I'm not a doctor.
Oh, sorry, Caroline.
Don't worry.
I've got you as Dr. Caroline Millar.
I know, it's an understandable mistake because the chair of the Confed is normally a doctor, but as of a few months ago, I'm the lay chair. I'm the acting chair, and I'm a lay chair, but I'm not a doctor. Right. I'm one of the lay members of the board. So thank you for the promotion, but I'd rather wait till Laura gets here. But if she doesn't get here in a couple of minutes,
I can give it a short while. If not,
sure.
Then we'll take it. While we're waiting, Siobhan, were you going to say anything by way of introductory remarks in terms of sort of your role as chair of the steering group, or were you here to answer more questions?
Well, I hadn't planned to say anything specifically, but I'm happy to if that would be useful. But I'm certainly able to answer questions.
Yes, yeah, I'll tell you what, just while we're waiting for Laura to join, is there any chance you can just give an overview of what your role is and what the Vaccination Steering Group is doing at the CCG?
Of course, no problem.
Just some scope of it. Thank you.
Okay, so I guess in the last few weeks, as you probably know, this has been a huge programme of work, but that had quite organic beginnings, shall we say, it became pretty evident really that we just wanted to put some robust process and structure around all of the activity going on with the programme, and certainly to ensure that we have a really embedded partnership approach, and working with our residents and our communities, and ensuring that the work that we were doing was coordinated and coherent, and doing the best that we could in order to ensure the uptake that we're aiming for. So we set up the Vaccination Steering Group within the CCG probably about maybe 4 weeks ago now, and that group's chaired by Steph Cochran, who a lot of you may know is one of our local GPs, and she's our COVID GP lead, and I'm acting as the senior responsible officer, so the SRO for that programme board, and really just trying to coordinate a lot of the activity and a lot of the really excellent work that's been going on locally, but also making sure that we're aligned to what work might be happening on a bigger footprint across North East London in particular, and linking up with opportunities and partners around the max vaccination site at Westfield and the XL Centre, and being connected to what's going on in the hospital hubs, etc. Originally I got involved because I was leading on staff vaccination, which we've worked really closely with the Homerton on, and now I've just taken on that role to kind of coordinate the wider piece for the local City and Hackney system.
Thanks, Siobhan, for that overview. That's very helpful. I think we'll come back to you shortly for some questions, I think. Thank you. Laura, welcome. No, sorry you had problems joining us. Siobhan was just giving us an overview of her work and what the Vaccination Steering Group is doing. If it's okay, can we go to you for an overview, and then we'll go to Caroline for some slides. Following your really helpful presentation at last meeting. Over to you.
Thank you, and apologies that I couldn't get in. Thank you to Mario for sorting me out. Oh, 2 dogs have appeared. Go away. Okay, so both sites are running at as much capacity as we can deliver based on the vaccination deliveries we get. So this week we are running Pfizer because that's what we got. We don't have any choice about that. John Scott was open today, will be open tomorrow. Both John Scott and Bocking are open on Thursday. And then we're doing 2 long days, Saturday and Sunday, 8 till 8 on both sites, all Pfizer. And that's fully staffed and all sorted. And I've just looked at the appointment book, fully booked. There are no spare appointments for this week. Everything is full now. For next week, we still don't know our delivery, so it's very hard to plan. We know we're getting AstraZeneca. What we have planned, because we've got we still have some AstraZeneca. So we've planned next Thursday, the 4th, at Bocking to do an AstraZeneca day, and Friday. And we've planned Tuesday at John Scott to do an AstraZeneca day using staff from the Army as well as our own staff. That will effectively use up everything we've got. So we're waiting to hear what we're getting in addition to that for next week so that we can open more appointments. So it's a bit of a pause whilst we wait for that. We hope to get that information tomorrow morning. What we'd like to do is run as many days as we possibly can next week on AstraZeneca, to just keep going at the pace we're going at, because the sites have really bedded in well now. They work well, the flow is good, the safety is good. So we're just ready to rock and roll, really. We ran 2 events for the Charedi community, one last Saturday night and one the previous Saturday night when Sabbath finished, starting at 8:30 p.m, going on till about 1 a.m. They were massively successful. The first one was, oh my God, if we had everything thrown at us, it was that terrible weather, that -2. We had the minister come, we had lots of rabbis visiting, we had Diane Abbott came. So there was a lot going on, as well as trying to vaccinate people throughout. But we did 364 vaccinations that night, I think. And then last Saturday night, we did 240 something from memory. We did it a little bit more tightly last Saturday. We didn't allow any walk-ins. We just did appointments only, and it was a bit calmer, and we managed it a bit better. But both those things were done in partnership with Cllr, and they were using Cllr vaccinators and healthcare assistants from the community as vaccinators as well. And I think that means a great deal. I am utterly convinced that there were people from the community who came to one or other of those events who would not have come to a mainstream service, as it were. I'm completely convinced about that. Some very vulnerable people as well. And we're keen to do more of that sort of work with different communities as people develop their ideas. Indeed, Sandra has asked us the system-wide piece of work going on around Turkish and Kurdish people, which is being talked about at the moment. So that is really good work. We're working our way through the cohorts. We're currently on cohort 6. There are still people in cohorts 1 to 4 who have been invited but have not accepted and been vaccinated yet. And we're reluctant to code them as declined, because the minute that happens, they disappear off the system. So we have what looks like a high refusal or hesitancy rate, but that is in part deliberate. We do have a high rate. That is in part deliberate because we want to keep those people as deferred whilst we still try and have a conversation with them through their GP practice to see if they can be persuaded to come, because otherwise they will get lost and we won't be able to go back to them. So practices are not coding those people as declined unless there has been at least 3 attempts, the third one being with a conversation with a clinical member of staff, either a nurse or a GP, because we want to be sure that we've done everything we possibly can to encourage those people in those first cohorts to come. And we'll carry on doing that. Cohort 6 is enormous. Cohort 6 is 16 to 64 with an underlying clinical vulnerability, and the numbers are big. And there's been quite a lot of confusion about the cohort and the searches released. And so there was this is a national thing, not a local thing. There was a search that picked up everybody who had ever vaguely had asthma, like me, who has an inhaler that I use occasionally, but I've never had steroids and I've never had a hospital admission. And those people were in cohort 6 and they shouldn't have been. So then the cohort had to be amended. So there were a few days when we were vaccinating people who looked on the face of it quite young and healthy. And it did feel a bit embarrassing, to be honest. And they were saying, we're not quite sure why we've been called when other people haven't. And it was a problem with the national search. But we made a local decision to carry on and not cancel, given that we A, had the vaccinators, B, had the vaccine, and C, had the people, even if they weren't quite the right people in quite the right order. Given that we weren't going to be able to book anybody else in, we just carried on. And so there is another complexity about cohort 6 now, which is to do with this new piece of research that's identified a group of people who are vulnerable, who now need to be shielding and prioritised as cohort 6. And Siobhan and I were on a call earlier today trying to work out how we prioritise those people for next week's appointments, because they are now the sort of top priority of cohort 6, if you see what I mean. So that's our latest challenge. Finally, we're moving to a new staffing model. We've been using GPs up to now because they've been the vast majority of people who've come forward to staff, some nurses, but the majority of GPs. But we're trialling a model of using medical students. supervised by GPs and trained and signed off by GPs. We're using medical students for two reasons. Number one, we have 100 of them willing to work for us. So we would have no problem with staffing if we could train those 100 and then use them. Number two, it is amazing experience for medical students to have. And the trial last week, they were absolutely buzzing at the end, saying they learnt more in 6 hours of working alongside experiencing GPs, working and talking to patients, dealing with vaccination, injecting and IT systems than they learn in, class in medical school. And number three, they're cheaper. So we can create an equally safe, cheaper model with a steady staffing supply. So we're transitioning to medical students and healthcare assistants supervised by healthcare professionals, all of it overseen by a GP every session. So that transition will happen over the next few weeks. And I think probably that gives you a flavour of what we've been up to.
It does. Thank you, Laura. I know Caroline's got a slide for us. I can certainly see there'll be some questions coming back for you. But Caroline, over to you. Caroline, we've lost you. I think you might be on mute.
Yeah. Hi. Yeah, the slide. I'm going to put the slide out now, but it relates to the slides relate to the paper that went out this afternoon, which has a much more detailed breakdown. This is based. I'll go to the presentation now, and then I'll talk you through it and see if I can make it work. Right. Caroline,
just to explain to everyone, you're the chair of the GP Confederation. Just for those, just for those that don't know.
Right. Mine's not letting me share. Okay, just 1 second. Here we go. Help. Slide. Okay, there we are. Right. Lot of effort for 2 slides, but here we go. There we are. Can you see that?
Yep.
Okay, so the paper that you've got is a very detailed breakdown of we've gathered feedback from people at both vaccine centres. We've had about 500 people who've responded. This picture relates to, it's like the keywords from the bits of feedback we had from John Scott, the general John Scott Centre sessions between the 5th and the 19th of February. So you'll see the huge amount of positivity in response to how people have felt about it. It has been absolutely extraordinary. We've had wonderful doctors, wonderful receptionists, wonderful volunteers, and a lot of very happy patients, which has been brilliant. So this shows you really what the feedback has been. You can see all the detailed comments on the papers that you've got in front of you, item 4 papers. And then this particular thing was feedback from 260 people who commented over those 10 days. Not everybody comments. It slightly depends how long they stay behind. So if we're giving out AstraZeneca, more people tend to stay behind for longer afterwards and can fill in the form. Sorry, not AstraZeneca, Pfizer. Whereas AstraZeneca, people tend to not hang around so long. So the amount of feedback we get varies little bit depending on the vaccine. The next slide is this is the very similar kind of feedback we had from the Charedi community sessions on the 13th and the 20th. As Laura said, we did have a few issues you'll see from the paper that you've got there that on the Excel spreadsheet that we had slightly more complaints about, complaints is too strong a word, but some negative feedback about queues and waiting. And that was partly to do with the fact that some people turned up who weren't booked in, partly to do with it being very cold, partly to do with lots of people who were new there. Just getting to grips with it all. But you'll see that the 20th, there was absolutely no negative feedback at all on the 20th event. So that ran very smoothly last weekend, which is great. So that just gives you a bit of feedback. And the other thing which made me smile looking at the feedback was several people in the feedback talk about how many people were smiling and how friendly everybody was. And I think it's quite amusing to think that people knew we were smiling, even though everyone was wearing a mask. So that's good to know. So that's that. That's from me. That's all I have to say for the moment.
Thank you.
Chair, if I may
Caroline.
just say one last comment about those smiling people, because our volunteer team are incredible. and they are the first smiling faces that people see, and they just the way in which they welcome people, the way they guide them and help them through the flow of the building, which can be quite confusing because it's a one-way system, and you're not quite sure what's happening to you somewhere you've never been before. They're just amazing, and I cannot thank them enough, the volunteers, and indeed some of them are on this call. I just cannot thank people enough for, especially those who were willing to come out and do a 8:30 till 1 a.m. slot on a cold Saturday night, which is really seriously beyond the call of duty. It's just amazing how the residents of Hackney have responded to this.
Thanks, Laura, and our thanks to Councillor Snell's been doing a fantastic job, and all the other volunteers. Our gratitude for that. Thank you. Just before I open it up for questions, can I just ask, Laura, one of the things you said in terms of deferring people up to 3 times, last time speak to a clinician to really try and get people vaccinated. What's your sort of success rate, as it were, from first point of decline to going through the 3 calls and actually maybe turning them, for want of a better word, to actually come and get vaccinated? How successful has that approach been?
So I hear anecdotally from GPs that it is the conversation with the GP that makes the difference more than anything else. It's the GP who knows the person. It's not any old GP. It's, I trust you, you know me, you know my family. And I'm now, quite a lot of it, I mean, I was talking to Deborah Colvin about this, and she said she had a very significant number of people of, I think she was telling me about her 80 pluses, who were saying, I want to wait and see if it's safe. And she got to the point where a few weeks ago she said to them, that's enough waiting now. It's safe. It really is. And I want you to book in now. I really, really want to book you in now. And most of them said, okay, doctor. So it is about that relationship and that trust, I think, for quite a lot of people. And that's why we need to keep enabling the practices to keep at this. And there is a little pilot beginning with using the town hall call centre to see if they can also nudge people into booking an appointment. That's less for those people who need more of a conversation, more for the people who've been sent the link on their phone and just haven't activated it, to see if we can say, you've had the link, just press on it, let's book you in now, let's get you done and dusted. Because 2 things, that means that person is seriously done and dusted and sorted out with an appointment, but also once that happens, that releases another appointment back for somebody else to book. So whilst they're waiting, whilst people have been sent the link and are not acting on it, the appointment book gets a bit stuck until they act and then release, if you see what I mean.
Yeah.
So that pilot, using the town hall staff to just nudge people into responding sooner rather than later, is very helpful.
Thanks, Laura. Can I open it up for questions from members? I saw Councillor Snell, then Councillor Plouviez. Councillor Snell?
I feel guilty getting praise because I'm afraid I just go for the that nice daytime slots. I haven't been doing those early morning or late ones, and people deserve, other people deserve much more praise than me. I mean, what was interesting, I was at John Scott after those outreach sessions, and there was a very clear increase in attendance from the Charedi Jewish community. And certainly one man I showed through said, my wife was here for the big community event, and that spread through the rest of the family. And I think all of us, certainly I was briefing a new volunteer the other day and talking through and say, right, and as they go out, when you give them their little button, just say it's up to them to go and tell all their friends to come through here. And another volunteer who started that same day just absolutely loved it, because people come apprehensive and leave generally happy. And if we could just spread that idea, it's for them to spread the word, then that, I think, is people power, and we should do everything we can to support it. I mean, Laura, you and your team have been doing a fantastic job. I mean, the key thing that is appalling to us all is the dumb social media largely inspired opposition, hesitancy about taking up vaccines. And certainly I was on one of the settings, and somebody in for the third time in a row, because you've just told us what vaccines are coming out next week. Our general line is we can't tell you when the vaccines are coming out, and they're all good anyway, and why do you think you get to choose your vaccine? So people generally don't know, and in one situation somebody turned away for the third time because he insisted AstraZeneca was somehow harmful, and that seems very much influenced by absolute nonsense rubbish on social media. And I think, as Mark Rickets said at one previous meeting, you know, they are, whatever vaccine take, they are loads more healthy than they were before. So we do our best on that front line to counter it. Don't believe the French president, you know, all the sort of lines that you can come out with. But interestingly, recent figures, because there have generally been figures that showed the Pfizer one was perhaps marginally better and gave you marginally more protection, but some of the most recent figures do seem to suggest that AstraZeneca is equivalent or better in some aspects of performance. And so generally getting that message out, but in particular, we've got a lot of add-ons to do at the moment. I don't know how we combat them when so much of this stuff is on social media. I mean, possibly just giving an info sheet to those of us who are volunteering at the centres. Clearly, we always do say, but speak to the doctor inside. They will talk you through the details. We're not medically qualified. We always say that, but just warming them up as they come is important. But I just wondered if we could have an update, because those latest AstraZeneca figures have been very encouraging. And the other thing that, of course, is encouraging is the growing evidence that this reduces transmission, that once you've had your vaccine, you are much less likely to give it to other people. And I just feel we've got to find some way of countering that misinformation. And there is new information to put out there. Sorry, I've gone on a bit, Ben. Thank you.
Thanks. No, thanks, Pete. It's useful hearing the volunteer's perspective. Okay, just before Laura comes in, Cllr Plouviez.
Thank you, Chair. The first thing I just wanted to ask is, certainly myself and several other people I know have got our vaccinations done through a hospital, because we were invited there first. Then almost immediately afterwards, after I'd had the vaccination, and several people I know, we then got invitations for Hackney. And I immediately did go on and say, but that the only way you can respond to the text is by refusing. So I just wondered how quickly it clears that you haven't refused, that you've actually had the vaccine somewhere else. And the other thing was, is it still just the 2 centres in Hackney? And is that likely to change at all, or are we doing the whole programme of 2 vaccines based on the 2 centres?
And thanks, Councillor Blue. Just before we come into Laura, Councillor Adams.
Thank you, Chair. My question is just, I heard that Jon Scott is doing a reduced hours for a session or something like that due to lack of people taking up the vaccine. But I kind of know at least a couple of people that have been struggling to book a slot for the past since last week until today. My wife managed to get one today. Just be content to get one for tomorrow morning. That's the slot that's available. I'm just wondering, what is the cause of that? That people are struggling to book a session, and at the same time, Jon Scott is reducing his opening hours.
Thanks, Councillor Adams. And again, I'll help you, Lewis. I've written them all down. I was going to take them all together. Councillor Oguzkanli.
Thank you, Chair. My question was about vaccine supply. Laura talked about difficulty in planning ahead. And it seems to me that there's a very short space of time between now and next week to invite people, organize everyone to come along, organize volunteers and so on. Is the main reason for vaccine supply, or lack of it, to do with manufacturers and how quickly they manufacture the vaccine, or is it to do with the national organizations and the supply we get from the national chain? And in addition to that, do you have any information as to the additional vaccines that has been promised to come into play and assist, such as Moderna vaccines, from March onwards? Thank you.
Laura, sorry for Lots of rolled up questions.
Okay,
Over to you.
it's good to get a list. Yeah. Okay. Social media, etc., etc. I think that Sandra may be better placed to talk about all of that. But the comms people are doing a good job to try and counter some of this craziness, and to try and debunk some of these myths. I know that Tara and Alice are working on a new leaflet to go through everybody's home. We put stuff on our website. It's out there, but it's very hard to counter some of the social media craziness. We actually had a lady come from a surgery, and she was very, very frightened about having the vaccine, and she was actually trembling. And I said to her, "Is it because you're frightened of needles?" And she said, "No, my pastor in my church has told me that the vaccine contains dead fetus material. But my daughter has insisted that I come because she wants me to be vaccinated. So I'm terrified because I don't know who's right." So I said, let's sit you down with our most senior experienced doctor who can talk this through with you. And then she was overjoyed and had the vaccine and was really, really pleased. But this is the sort of stuff we're up against. It's, this crazy stuff out there. Dr. Taseen Khan, who's one of the Primary Care Network GPs, has done a lovely leaflet about debunking some of these myths, and it's on the Confed website, and I've sent it to Alice. So we absolutely have to keep at these major messages all the time. We have to talk about, I don't know which vaccine is better. I'm not sure anybody knows yet. It's a very early changing situation. What I do know is that being vaccinated is way, way better than not. So I would say, and this is what I say to people at the centres, have what we can give you right here, right now, today, because protection will begin a few weeks after you have this vaccine. The longer you wait, the riskier it is. So, we need to keep banging on these sorts of messages, I think. Somebody who had, Dr. Plouviez, who had the vaccine somewhere else and then got an invitation. It has been taking up to 3 days for the data to get from Pinnacle into the record, the GP record, in order that we know that in order that the record is updated and the GP knows not to invite you again. That is getting better, but I'm not sure whether all the data from all the other sites, like the MassVac sites, is coming through. I know there's national work going on, all of that. So that may be why people get an invitation when they've already had a vaccination somewhere else. It's that data catch up that's difficult. We will stick with our 2 sites. We won't open anymore. They work well. We can manage properly infection control and safety. We are using practices. We are enabling practices to do some AstraZeneca vaccination themselves for people who are too frightened or not able enough to come to the centre. So that is the way we're supplementing our offer at a very local level, especially for people who are sort of 80, 70 plus, who really are scared to go anywhere other than their own surgery. And of course, we've done a massive piece of work on housebound patients. John Scott did have reduced hours for 1 week about 3 weeks ago. Yes, sorry, thanks, Siobhan. There are also 2 community pharmacists offering the service in Hackney. John Scott did have reduced hours about 3 weeks ago, and this was when we weren't allowed to move to the next cohort down. So we were in that unenviable position of having vaccine, having staff, but because we couldn't go to the next cohort, because we were waiting for the whole country to go to the next cohort, we couldn't. Everybody who had wanted to be vaccinated from the previous cohorts had been, and we had to close for 3 afternoons. So we did half days instead of full days. But that's not the case now. We're open as much as we can be with the vaccine supplies we get. So we've got over that problem. Supplies drive me mad. Yes, you are absolutely right. To not know what your supply is now for next week and then having to plan at the last minute is basically my life. last week we didn't know till Thursday night what we were getting the following week. So it's always a mad dash. They keep saying that that will get better. It does, and then it doesn't again. And I don't know whether that is national supply or manufacturers' supply or moving vaccine around the country to other areas that are behind. I genuinely don't know what it is. It could probably be a mix of all of those. I think it will be better because, of course, quite soon we have to start doing dose 2 for all those people who had their dose 1 12 weeks ago almost. And we have to have a secure supply for that, of course, otherwise people will miss out on dose 2. So I suspect there's a little bit of that going on, pre-planning as well, to get ready for that. So it's I would love to know for the next month, because we could open loads of invitations, we could fill it, we could staff it, but I don't think anyone in the country has managed to get that yet. Have I covered everything?
Thanks, Laura. Yes. Thanks, Laura. I've got, we're slightly over on time, and I see Jon Williams and Councillor David would like to make brief comments. So can I ask both of you just to make it quick, please, and then so we can then get on to vaccine hesitancy. So Jon, over to you. Jon, you're muted still for some reason. Can't hear you still, Jon.
Do you want me to just go ahead?
Can you hear me now? Sorry,
yeah,
can you hear me?
We got you.
Yeah, sorry about that. I just really want to caution about the way we speak about people who are vaccine hesitancy. Describing them as crazy is really unhelpful. That will play into those anxieties and those people's behaviour. We really need to be very careful about the language we use. We'll hear more from Jake and Peter now, but it's really important that we don't use the word crazy, because those people will play against that and kind of justifies their position. And I'm very pro-vaccine, believe me. Do not play this game with them. Thank you.
Yeah, sorry, Jon. I didn't mean the people. I meant the theories. But your point is well made. Thank you.
Thanks, Jon. And Councillor David?
Yes, I was going to make a similar point, but then just to build up on what Jon has said, we have to recognize that it's not as simple as, you know, some people say it's my pastor who says there are demons in the vaccine. There are people who are looking at it from the angle of, for example, in Australia, where they pulled out 50 million vaccines because of concerns. So we need to address everything, and then don't just make it, you know, kind of it's the loony people against the sensible people. So we need to address those things. I've noticed that there was a very helpful meeting on Thursday last week. I think Dr. Husbands was there. I think some of the outcomes of that should be taken on board. It's very crucial. There were points about this made. Thank you.
Thanks, Councillor David. I'll take that as a helpful comment, because we're now going to go on to segue into item 5, which is vaccine hesitancy. And as Jon alluded to, we've got Peter Merrifield, welcome, and Jake Ferguson. Peter is the chief exec of a group called Support Where It Matters, and he's been doing a lot of work in terms of vaccine hesitancy. I know he's sharing a platform, I think, last week on this. And Jake Ferguson, we all know, is the chief exec of the Hackney's Council for Voluntary Services. So I think, are we going to, can we kick off, Peter, with you, with your thoughts in terms of the hesitancy and what some of the challenges are?
So thank you very much, and thank you very much for inviting me to come along and say a little bit on this. And I suppose it's quite interesting and timely in terms of the comments just made by Jon and Councillor Kofod in terms of language, because there is a sense within particularly African Caribbean communities around the word hesitancy and the sort of implications of what that means to wider society. And it's also really interesting when we think about those people who have the right to make a decision not to have the vaccine as yet, as well as much as I am pro-vaccine. I've had my vaccine. I am certainly an advocate of it. I have to wholly respect other people's decision to choose not to have it at this stage. And one of my biggest concerns already is the backlash that particularly people from African, or in quotes, BAME communities are going to experience if they are seen to be not taking this. And I've already noticed an article, I think, that came out on the Daily Mail this morning that started talking about these people who are potentially going to put the whole rollout at risk because they don't want to engage in this. So for me, as a local organisation and as a member of that community, I think we have to be ready for the fight back to protect our communities, as well as actually encouraging. So that's just something that I think needs to be certainly thought about. In terms of, you know, I'll just be very quick about really what sort of brought support when it matters into this space. You know, a lot of our concerns were when the first pandemic broke last year, and, you know, we heard politicians and clinicians on the TV every day talking about the disproportionality of deaths within our community, and that quite often it was as a result of sort of, in quotes, underlying conditions, and you know, even given a sort of sense that it might be because these people don't live very well or they don't look after themselves, and as a result of this, this is why this is happening. And that drove me to actually go out and actually talk to the community, and it really blew away the myth that people from African Caribbean communities are hard to reach. When we went out across Hackney last summer, we engaged phenomenally with the community, and they gave us real useful insight, you know, right back then, about the concerns, and I use the words concern rather than hesitancy, around the vaccine. And I suppose if we fast forward to where we are now, for me, some of it's already been touched on. Fantastic work, Laura and all of the rest of the team. I'm proud to be a Hackney resident to see how this rollout has gone so successfully and so succinctly. I noticed the conversation around the work that was done for the Jewish community and the similar work that's been planned for the Turkish community. And one of my concerns is that we're slightly behind the curve when it comes to the African Caribbean community. I would have expected that actually we were fully aware of this from last year, and we would have had measures in place to start ensuring that we were ready to take on the fight. And for us, we're in a war. We're in a war with social media. We're in a war with influential people within the African Caribbean community who are gatekeepers, right, of the community, and they are not always in favour of actually, they have their own, shall we say, biased views around it. So the way that we're looking at it at the moment is we have to look at how do we develop a strategy using social media. One of the biggest opportunities that we've had to challenge, to support our communities has been taken away from us because of lockdown. So the kind of things that Swim is used to doing, like going out and doing the heavy lifting and talking to people, putting up information which is culturally appropriate, we can't do at the moment. We're limited to. So it's a strategy around social media. How do we actually develop a strategy which penetrates both young people, who we believe have to be one of our strongest advocates to encourage other people within the community? I mean, if we think about the Stop Smoking campaign, or for those old enough, going back to Clunk Click, young people were the ones that actually encouraged other people to stop smoking because they wanted them to still be around. So how we utilize young people, who on the one hand are quite cynical of this, but on the other hand can be a vehicle to actually getting the social media message out there. Some of the things that came back from the meeting that we had, the workshop we had last week, was around people within the community with specific health conditions like sickle cell or other types of health conditions, which brings up anxieties about the implications of having a vaccine with those conditions. And so there's something around how we develop the messages. Another key area I think we need to do, and we're planning to do, is getting into those networks. So, you know, getting into those African networks, those Caribbean networks, piggy banking those networking meetings, sharing information, using our websites to put accurate, clear information out there. And we have to be diligent and consistent about getting this, taking the fight out into the community, because we really are up against the fight, really, when it comes to the African Caribbean community and all what's whirling around at the moment. So they're just some of the things that I think we need to really be looking at now. And SWIM is actually preparing to actually take this piece of work on in conjunction with obviously public health and the Federation to see how we can improve things. So yeah.
Thank you, Pete. Thank you, Pete, for the very insightful and helpful remarks. Siobhan, I see you've got your hand up, and I want to bring Dr. Mark Rickets in as well. Siobhan?
Yeah, so thank you for that, Peter. I was aware of, I think you did attend the event last week, and obviously Jake played a leading role in putting that together. And we very much want to work in the way that you've described, working with people who understand and know communities in terms of both that, getting that messaging right, but also providing ways to access the vaccine potentially. So there's been quite a lot of talk about outreach models or roving models, and notwithstanding some of the sort of technicalities that we have to manage in terms of the vaccine, because you're just having to administer it has got some issues about it. We're very keen to look at those ways of working in order to be more visible and be more available to people where they live, where they work, where they shop, you know, where they know each other in the networks, as you say. But what we really want to do is build that approach with the community assets and the people who know the communities, and so that we're targeting where there genuinely is an issue, rather than you know, doing lots of things and maybe not being as effective. So I guess we'd be really keen to have that working relationships with organisations like yours.
Siobhan, just before I sort of bring Mark in, can I just get a grip? Who's holding the ring on this in terms of that, however we frame it, vaccine hesitancy, vaccine concern amongst, say, different community groups, looking at, say, whether it be a case of looking at the figures and which community groups might be disproportionately not taking up the vaccine more than others, and having an overarching view on a strategic playing field in Hackney as to how we're pulling all our levers and coordinating it. Is it you? Is it Mark? Who's the? Well,
it will be the Vaccine Steering Group, I think, and that's a, you know, like, but it's a partnership effort in order to address and undertake the work that we need to do. We need our partners to help us with that work, but it will be driven by, I'm hoping, by the Vaccine Steering Group, so that just so we can have some clarity and ownership. I mean, it's an NHS programme, so we're the ones tasked with delivering. So we need to make sure that we're working in a way that engages with other people who are able to deliver things that we maybe can't. So that would be the approach, really.
Thanks, Siobhan.
The data Mark. Is. Say again.
Oh, sorry, I was going to go to Mark. But go on.
All right. Sorry. Yeah.
Mark, did you have your hand up before, and I didn't come to you? Apologise.
Well, yeah, I did. I mean, it was only really to pick up a couple of other points about the previous conversation slightly. I mean, one was around the fact that the vaccine nationally is slightly constrained until about the middle of March, from last week to the middle of March. So that's a manufacturing thing. So everyone is just facing a slight dip. It's not a massive dip, it's just a slight dip. So, and then there's a big acceleration from mid-March onwards when we start looking at even more cohorts. So that will be playing out locally in terms of the number of clinics running at the moment. And the other thing, which I guess relates directly to number of sites. The number of sites is controlled nationally. You have to get approval of sites. But there has been an offer to invite pharmacists, another wave of pharmacists to come forward. So there may be those sites coming forward. We have 2 in Hackney at the moment. And then the last thing does directly relate to what we were just talking about, picking up Siobhan's point about having a multitude of ways of having conversations and meaningful engagement in a kind of really kind of focused way, is also paralleled by having a multitude of offers about how you deliver the vaccine. So we've talked a lot about those different things, but one we haven't spoke so much about, and I'm doing quite a lot of work at the North East London level in terms of getting this smoothed out, because there's lots of kind of regulations around how the vaccines are licensed and how they have to be managed and all these sorts of issues, is trying to make it easier to run, if you like, pop-up clinics. So now, and as Laura said, we can start having one-off bespoke clinics in practices in the clinical sites. You have to have your site accredited to make sure it's safe and respects the sort of how you handle the vaccine, the people delivering the vaccine are all properly trained, all the things you have to make sure are in place, proper infection prevention and control. So we can do that relatively easily in practices, because obviously they're clinical environments. We want to make it easier for that to happen in town halls, in a place of worship, a leisure centre, just really popping up on the estate, in the luncheon club, and then you still need a clinical lead to run that, because they have to, because that's part of the licensing requirements, etc., etc. But you could have all manner of creative options. It could be from an enthusiastic primary care GP centre. It could be from somebody from the community services or the mental health service. Lots of others, or a pharmacist who goes out and does things. And just trying to make that. At the moment, there's been a few clinics run from mosques. Of course, the one for the Charedi community was run from the John Scott, which has already been an accredited place. So just to make that much easier and smoother to do, I think would be really helpful, so that you can get much more creative about the offer, really matching the sensitivity of the local kind of piece that you're trying to get into, and that's the sort of making that easier as a work in progress. But hopefully we'll see more and more of that as we move forward.
Thanks, Mark.
Can I just say, so I think, Mark, that really is hitting the button, really. It's about how do we become really agile, and how do we get a bit granular and come down to from the national level, the local level, down to the literally ward level, you might say. So, for instance, the Kingsmead estates or the Pembury estates, or, where we know we've got pockets of cohorts that are concentrated, and there are all the other unfortunate inequalities that are also happening at that point. Do we position ourselves there? And I think that was one of the successes of the work SWIM has done, is that we positioned ourselves in areas where we knew the community were. And as a result of that, we naturally engaged with them. We look the same, we talk the same, and so therefore and I suppose, just to end on this, I think the spin-off that comes from that kind of agile, flexible, culturally responsive approach is that people then offer to become even more involved in health-related issues. They give you their number. They say, yes, you can contact me. Yes, we're happy to be part of a survey. And you get some of that more additional rich information. So we have to think smartly like that, Mark. I think that's absolutely correct. And Siobhan, I was just going to say, I think we're a bit behind the curve, so it's about us getting together really quite quickly and starting to map out and scope out how do we ensure the African Caribbean community is being addressed now, really.
Can I just make one last comment? It's about the scalability of those offers. They're going to be bespoke. They'll probably manage to vaccinate hundreds of people through programs like this, but we've got to get through ultimately tens of thousands. So there is always an issue that if the people who can will be encouraged to go to the mass vaccination sites, particularly as we get down to those really large cohorts of people of younger age, because if it's all so easy just to pop down to the kind of your local place, they'll get flooded, and we'll lose some of those people who don't have the most assertive elbows. So actually it's a subtle kind of, as we go forward, to make sure this remains focused at the people who really need it, without you know, because the numbers we do have to vaccinate eventually are huge.
Thanks,
Anyway,
guys.
so just make that point.
I just want to go through those that have got there. It's good when it comes into sort of an iterative discussion, but I just want to make sure I've got everyone in. Caroline, did you had your hand raised, and I've got Cllr Snell, and then I think Alice Beard as well. So Caroline?
No, I've lowered mine now. What I wanted to say has been said. Thank you.
Fine, thanks. Cllr Snell?
It's a question that comes out of what's gone previously. If I wanted to contact and move opinion within the African and African Caribbean communities in Dalston, I would work through the churches, the Pentecostal churches, and basically because there just happens to be a cafe owner who is a pillar of the Ethiopian Society. So if I talk to those individually, and I've got their email addresses and their phone numbers, who do I contact to say, and we should be doing this across presumably every councillor and every ward, are they welcome, and who do they contact to either get someone to go talk to their group and reassure them that it's safe and explain the procedures for getting vaccinated, and possibly to put on that local provision that Peter was welcoming so much. So am I allowed to do that? Shall I get on with it? Thank you.
Okay, thanks, Councillor. Now, just before we come on, I had Cllr Adams and Cllr Plouviez, and then I've got Alice from Comms as well. So Cllr Adams?
Right, thank you, Chair. My point is that when we're talking about the Africans, we have Anglophone and Francophone Africans. So we are not homogeneous, you know, like talking to a group of people. So we need to actually look for ways to actually diffuse some concerns of the Anglophone Africans that got the information from French-leaning social media, whereby there was some information before that the French doctors carried out a lot of experiments in Africa and this and that. So about hesitance, there's much to it than what we're just talking about here, because there's been a lot of information out there that actually concerns people. And secondly, when we're talking about the people that are taking over this vaccine, when we're using percentage, the percentage doesn't tell us the whole truth, because 1% of 1 million is a lot of numbers. But when you say 1%, people see it as a low number. So communicating this to people, I think we need to actually be giving out true figures that can actually tell the story. Because, for example, when you talk about the clinical tests, you know, that people carried out before the vaccine, they will tell you it's a low number, 7%. 7% doesn't mean anything. But if you say 10,000 people from ethnic minority participated, people can relate to that. That's a lot of people. So that would be my suggestion, that, you know, probably we need to actually put this information out there in a different way that people can actually, you know, that can create more confidence that, oh, if you say, for example, 500,000 Africans are taking the vaccine, most people will be more confident to go and take it, because 500,000 is a lot of people.
Thanks, Councillor Adams. Cllr Plouviez?
Thank you, Chair. I wondered if in the research people have done, and the one of the things that I've come across, but very anecdotally through social prescribing, is economic concerns. So people who think that the vaccine may, you know, like a flu vaccine might, you know, might be slightly worse, make you have to have a day or two off work, which people can't afford, and obviously also getting to get the vaccine. So that, you know, that has come up as a real concern for some people, and I wondered if that was something that people were finding as well, and it may also affect people who are working as carers, because I'm one of the people that I know of who's refused the vaccine because they're working a care in the community job, and they're doing literally two people's job because somebody is off long-term sick and they simply don't feel they have the time. I just wondered if that was something that anybody had come across as well, because it's again focusing in those particularly deprived communities.
Thanks, Councillor Plouviez. And Alice from the comms department here at Hackney.
Yeah, thank you, Chair. It's just a quick point, just and kind of aligns to everything everyone's been saying in the past kind of 15 minutes, but mainly to your point in terms of who's coordinating all of this. And there is a subgroup of the steering group that has been set up. So we met for the first time on Monday, and that includes comms and engagement colleagues from across the system. So that includes LBH comms and engagement colleagues, colleagues from City. It also has HCVS members and others. There's a huge number of public health colleagues on there as well. So this group is really looking at both the insight that we're getting from various places, including our community conversation events like we had last Thursday, but also from our community champions work, which the public health team leads on. But then we're matching that up with all of the kind of hard data that we're getting from the public health team as well. And that group is kind of weekly reporting to the steering group on what we should and could be doing. So just to let you know that that's going on in the background. We've only just been set up. As I said, the first meeting was on Monday, and it's meeting weekly. But just to let you know that that's how we're kind of coordinating it from a system point of view. And Peter, thank you so much for all of your insight. We'll definitely be in contact with you and your team moving forwards. Obviously, there's a lot of work that's going on across the system, and it did really get to the point where we needed to start coordinating it. And we can obviously keep you updated on that as and when you need us to.
Thanks, Alice. That's very helpful. Dr. Husbands.
Thank you, Chair. I just wanted to respond to Cllr Plouviez' question really quite directly about whether those sorts of economic concerns about needing to take a day off or either to get the vaccine or in the wake of having it have been issues for people, and that has come up in our insights. I couldn't really give you the percentage of people that applies to though, but it's definitely a concern for some people.
Thank you, Dr. Husbands. Siobhan, do you just sort of, I mean, sort of the response group, do you, just to close this item off before we move on to Dr. Husbands in terms of an update on where we are with testing, just in terms of the feedback you're getting here about people's experiences about economic misinformation. I mean, so how's the steering group then taking this forward? What you're meeting weekly, and can you just give us an overview about how this is being fed in to an actual results?
Yeah, so it is as Alice described. We have got this working group that is gathering the insight and looking at the intelligence that comes from community champions, organisations, people, grassroots organisations, people close to the communities. And we are then sort of cross-matching that where we know, I mean, we have started looking at the patch geographically and looking at where rates look lower and starting to think about what that might mean in terms of facilities or suitable sites. That type of planning is starting to emerge, and then thinking about who we can work with as community organisations to champion these kinds of activities, I guess, as well. If we are going to do outreach work and outreach clinics, I think it's really important that there is a presence from the community as there's a trusted voice. It needs to be something that we develop in partnership. So it's quite early days, but we are pulling together the component parts, I suppose, in terms of how we would put on an approach like that more systematically. But we're learning from what happened with the Charedi community and how sometimes a fixed building like the John Scott is the right building. We might not need to go out into smaller patches, but with other communities it might be that we do. So it's really just trying to refine the approach depending on the need of the cohort that we're thinking, or the vulnerable group that we're thinking about.
Thanks, Siobhan. What I'm going to do
is very happy to come back again. Maybe
I think
tell you a bit more.
I think Councillor Snell was just there in terms of sort of his comment in terms of contacting passers and local people in his community. Is this something that, I mean, and other councillors may sort of have those questions as well. Is this something you want to take away and think about in a more sort of structured way, or in terms of sort of individual councillors making contact with sort of their community representatives in their ward?
I mean, I think it'd be good if Alice maybe took that to the group and talked a little bit about how best to, because obviously councillors are also key members of the community who understand their communities and know their patch and know know key people as well, and that is a rich source of intelligence that we want to work with. So but we probably might need to think a little bit about how that's managed and coordinated. But I think that's a very rich piece of the puzzle that we would want to work with.
Thanks, Siobhan. I mean, I think this is clearly going to be a matter of ongoing interest to the committee. So I certainly think at the next meeting, in terms of we very much appreciate, it's still very early doors, but an update about where we are and how we're sort of monitoring progress is clearly something we'll be interested in going forward.
That's no problem.
So thank you very much, everyone, for that. And so we're going to go on now to the update in terms of where we are sort of with the figures from Dr. Husbands. Other sort of clinician members, if you appreciate you've been working flat out, so please feel if you want to log off the call, we totally understand, but you're very much welcome to stay. So Dr. Husbands, for item number 6, our update on where we are.
Thank you. I'm going to show you the presentation. You should have received it earlier, but
we did. Thank you.
Just because it's easier to watch it at the same time. Now, please let me know if you can't see it. I'm not getting a. Yeah, I was going to say I'm not getting a thing telling me that I'm presenting. Let me just go back. Normally, right. Let me just try that again. Okay. Right. Okay, so can you see it now?
We can.
Good. Right. Okay, so just to start with the headlines, over this last period, when I last spoke to you, the infection rates were really high. Things were not looking great at all, and since then the situation's improved considerably. So the cases, the numbers of cases, the incidence rate is coming down, and alongside that, the positivity rate, as in the percentage of tests that come back positive, has also gone down. The positivity rate is important, if you remember, because it helps us get a sense of how much circulating virus there is. So even if you get a lower incidence rate but a high positivity rate, that just means there's not enough testing going on. But these numbers are both going in the same direction. So we have actually had a bit of a reduction in testing, not entirely surprising for a couple of reasons, including that people are in lockdown. Including with the asymptomatic testing, as in the lateral flow tests, only people who are leaving the house on a routine basis are likely to be taking up that offer, and that's being targeted at them. But also, because there's less infection circulating and that there's less transmission, there are also going to be less people or fewer people with symptoms. So actually seeing testing rates coming down is not a surprise, and is expected, as long as it doesn't go below, it doesn't get so low that we believe that people are under testing or not testing it when they should be, then we're not concerned. So that's all very good. There are still, the rates remain high overall though. I'll go into the details. So it's much, much improved, but still high, particularly in certain age groups, particularly the young people, but there's also a fairly high incidence rate, higher than by age group, in the 60 to 79-year-old group. And there's different incidence rates in different wards across the whole patch, as we've seen before. And we're also seeing, again, some ethnic disparities, but not necessarily in the way that we have done over previous months. Things are also beginning to improve in terms of hospital bed occupancy and the ability to staff the hospital with fewer absences, and we'll go into that in a bit more detail. So this slide is showing you the graph of cases by date. So the what looks now like a tiny peak at the beginning of on the left of the hand side of the graph is the peak, the first wave, from the first wave in April, in March and April last year, and then you can see that we went up to astronomical over 2,000 per over 2,500 per 100,000 in January, and we've come right down again to almost the levels where we were at the peak in the April peak, in the April wave peak last year. So as I said, that's good, but it's still high. So our incidence rate yesterday was not yesterday, for the period, the 7-day period from 12th to 18th of January, was 69 per 100,000. So that's a massive improvement over 2,500, but still high. And you might remember back in September or in the summer, we were agonizing over getting over 50 per 100,000. So we're still at a level where we've got what we would consider to be high circulating levels of virus. The test positivity rates, as you can see from the third bullet point there, are down to 2.5%, but that's still much higher than we would expect. During the summer, when we came out of the late spring, I should say, when we came out of the first, we'd come out of the first lockdown and we'd come out of the first peak, and in London at least, but also across the whole of the country, there were some hot spots where there was very high infection rates, but generally there was a low prevalence of virus across the whole of the country, and we were only getting around 1% or between 1 and 2% of tests returning positive. So I'm just giving you that background there to help you understand why it looks so much better, but it's still not good. And I mentioned earlier that the testing rates have declined, but that we would have expected that in this context. So what this sort of tartan rug or heat map is showing you is by age group and by date, actually by day, over the past few weeks, what the incidence rates have been for each of these age groups. And if you just want to eyeball it, the darker the colour, the higher the number. So as you can see, as we're coming up to the present, all of the rates are going down, but the significant one to look at is this 16 to 24-year-old group, where you can see that there's still a fairly deep orange, and the most recent incidence rate in that age group is 113 cases per 100,000, where by contrast the 80 plus group is 67 per 100,000, and the 25 to 29-year-olds is 70 per 100,000. So the two groups with the highest incidence still are the 18 to 24-year-olds and the 60 to 79-year-olds. So we would expect a lot of transmission in younger working age people. We know that that was the case before, particularly when students were in university or college. And in particular, working people in this age group are likely to be working in occupations where they have to leave the house. And therefore, ongoing transmission, even though people are tending to be complying with the lockdown restrictions really very well for the most part, it's still most likely that transmission will occur in this age group because they're most likely to be out of the house. What's concerning is, in particular, is the slow tail off of infection rates in the 60 to 79-year-old group because of their greater susceptibility to severe illness or even death in this age group. But all of the rates are coming down, and as we've heard just at length, most of the 70 plus year olds in the older age group have had at least one. Many of them, actually the majority, so although we've got a big gap, still the majority of them have had at least one dose of vaccine. In terms of the geographical spread, we've got a completely new pattern from the one that we were reporting on a lot in previous months, where our northern wards are actually way down the pecking order now, but we've just got this rather sporadic, if you like, incidents with that's not even to do with wards being contiguous or anything. So that there's no specific geographical pattern. It's just some wards are still have had increases in recent weeks, but most of them have had a decrease. So it's not clear if there's anything specific driving that, and that's something that we're just watching very closely. But the general trend over the whole of the borough is downwards. And then in terms of ethnic groups, again, so this is a similar style of presentation as the age group one that we just looked at, where it shows you by over the past few weeks by date and by ethnic group. And again, most of the groups have had a substantial fall in incidence rates, as you can see from the colours getting lighter. Some of the numbers, because the population, the denominator, the number of people in that population group is quite small, are a little bit uncertain, and that's why they've been presented in red, as in the figures in red on the chart. But as you can see, that there's been a decrease generally. Of particular note is the decrease in incidence among the Black population, and there's been a decrease also in the Bangladeshi population. And if you remember, when we reported on this before, particularly I think in the summer when we were specifically looking at ethnic inequalities, excuse me, the highest mortality rates were among the people with Black. Well, I should say people who were of South American or Caribbean origin, or and I have to say, we had to say it like that because that was the information that we had from the death certificates. So we couldn't really say they were Black. It's just, but we could infer that they were very likely to be, or people who were of Bangladeshi origin. So those were two of the most vulnerable or susceptible to bad outcomes from this infection for us in Hackney, and they both had falls in incidence, but it hasn't fallen quite as sharply for the Bangladeshi group. The other group has also fallen significantly, so that although that number 115 looks relatively high, it's fallen from a much higher level. It's difficult to determine exactly what that means in terms of our local communities, of course, because lots of people identify themselves as other because there's no specific category in the way that the ethnicity is recorded on the systems when you book a test, for instance, that they relate to. So they just tick other, and that's completely understandable, but it doesn't help us understand whether these are people from the Turkish community or the Charedi community or the traveller community or whatever, or even not Black Caribbean and not Black African, but Black South American or whatever. So it's so other can be is a mixed category that we need to understand a bit better, but we can recognise that there's been a significant fall in incidence rates in that group. And last but not least, this declining rate of infection has had the desired and intended impact on the NHS, which is reducing bed occupancy and along with and reducing critical care bed occupancy as well. And along with the infection rates going down in the community, they appear to be going down among hospital staff as well, because there are fewer COVID-related absences being reported as well. Having said that, though, bed occupancy does still remain relatively high. So as you can see from the last bullet point there, 65% of general and acute beds, that's what the GNA means, are occupied, and 85% of the critical care beds are occupied. And if I remember rightly, over 30% of the critical care, of the occupied critical care beds have patients who are in there with COVID. So things are improving, but it's still a very serious situation, and there's still a lot more work to do.
Thank you, Dr. Husbands. As always, that was incredibly informative. Members, any follow-up questions from that? Can I just ask, in terms of, I think it sort of, if you look at the national figures over the last sort of week and a half, 2 weeks, it's sort of, it is dropping, and then over the last 2 weeks, you've sort of seen a plateau at sort of between 10 and 12,000 cases a day, and sort of the rate of decline doesn't seem to be continuing. But in Hackney, we are still seeing decline. So that national trend, is it right that we're still seeing decline in Hackney, but whereas the national trend seems to be plateauing a little bit in the last week or so?
That's right. So the national trend will reflect the what's happening at local and levels. So and at local levels, there are different pictures. So even across London, although we've had a general fall everywhere, there have been some boroughs where they've had an increase in the last week or two, and some where they haven't had quite as steep a decline in the numbers of cases as we have in Hackney. And then across the country, we've still got areas like in the northwest where as you know, they've had they had a very difficult time all through last year, and it's taking longer for their rates to come down now as well. So we'll get to a certain point where the fact that some rates are still high in some places, even if they're very low in other places, will just make it look like we're levelling off in terms of the national picture.
Thank you. Councillor Snell, and we've got Jon Williams.
Thank you, Dr. Husbands. I think any person with a scientific background absolutely loved your contribution to in North East London, where you commented on the statistical validity of some of the figures that you were putting forward, and we thought, right, there's a proper scientist. You're going to be on more or less on Radio 4 in no time. So I know that you don't give us figures that you can't rely on. But what I think is interesting on these figures that you're presenting here, put me straight if I've not understood it. Across inner North East London, we were being told that Southern Asian communities in general were actually showing equivalent rates of take-up of the vaccine, and that the problem over the whole of the bigger region was very much with the black communities, and in particular with black women. Now, if I'm looking at these figures, and obviously you're saying the others, you can't really categorize them, but it slightly looks to me as if we aren't in that situation, that in fact we do have a problem with our South Asian communities. You know, our conversation earlier on was talking about the black communities in Hackney, and clearly we need to unpick that more grouping, because I suspect there are quite a lot of South Americans in Hackney, and are they a community we need to be getting the message out to? So just tell me, have I understood that correctly, or are my statistics wrong?
Just before you do, Sandra, can I take Jon and Councillor Spence?
Thanks. Yeah, my next question is more about the schools that are going to be opening on the 8th of March. The central government's going for a big bang option of just getting everybody back. Is public health able to work with the schools to monitor that situation to ensure that we don't have a sudden upsurge at all in infections?
And Councillor Spence?
Yeah, hello. I wanted to ask Dr. Husbands about test, trace and isolate, and at what point does the prevalence of COVID in Hackney fall low enough for you to be able to effectively apply test, trace and isolate to get on top of COVID-19 in the context of the resources available to you?
Okay, Councillor, Dr. Husbands.
Okay, thank you. So to start with Councillor Snell's question, we're looking at, or you're thinking about, two different data sets, and they're not telling you about the same thing. So what I just presented was about people getting tested and the number of positive tests or cases of infection that we're picking up. And earlier we were talking about whether or not people were likely to get vaccinated. So it's right that certainly during the first peak and more generally, not necessarily specifically in Hackney, but more generally across the country and in other countries too, it's been found that, not all countries, but in some other countries too, it's been found that people black people, that's the easiest way to describe it because they define themselves in different ways in different countries, black people and people of South Asian origin, so particularly Bangladeshi and Pakistani origin, not so much Indian origin, were more likely to become very seriously ill or die. That was certainly true for us in the first wave, and therefore, you know, as we heard from Peter Merrifield, possibly the groups that we should be targeting most directly with the offer of the vaccine. But the fact that people are getting infected or not getting infected does not necessarily correlate with their likelihood or not likelihood of taking up the vaccine. So, but our picture is a bit different from in other places where, so for instance, we've had a significant decline in the numbers of cases in black people, and deaths among people that we might be able to infer are black have been much lower in this second peak than they were in the first peak, but that hasn't necessarily been true. Public Health England published some data doing some analysis of the second peak a couple of weeks ago. It's on a PHE blog on their website, and they were basically saying that this new analysis reinforces what they've understood from the analysis they did of the data from the first wave, but the picture for us locally looks a bit different. So it's something about the way that people have engaged, and or that people in Hackney who are of Bangladeshi origin have found it much more difficult to do things like, say, work from home or whatever that keeps them in a more protected from the virus, whereas black people have found ways to protect themselves relative to Bangladeshi people. Still, they should all take the opportunity, get the information, and make a decision about taking the opportunity to get vaccinated. In terms of schools going back, so there's a quite well-developed testing regime being put in place for schools, and we've been working with schools since before Christmas. If you might remember, there was going to be this Christmas break, remember, when we were in tier 4, and there was going to be this, this time off, and lots of people wanted to get tested before Christmas because they actually thought that was going to be a license to go and have fun. And so since before Christmas, we've been working with a number of schools in Hackney, and some of them have got very well established testing, on-site testing processes and facilities already. Stoke Newington School being the exemplar of that, and people have even come to visit to see what setup they've done, and my team has supported them with that all the way through, and all the other schools. And from the 8th of March, when all the schools are due to go back, there's not going to be any kind of staggering. Secondary school pupils and staff are all going to be asked to and given the test kits to test themselves twice a week. So the first 3 tests they'll do either in school if they've got on-site testing, or at one of our local asymptomatic testing stations. So if they're going to do it in school, or if it's a school that hasn't started testing yet but wants to, we will support them to set that up. If they haven't got the space or facilities to do it in school, then we will work with them to find a way to get all of the children and staff through the asymptomatic test sites, because they clearly can't all go through at the same time, and to make sure that they can get that, and that's just so that they can learn and be confident with it, so they can then test themselves at home. But of course, all the time we're having regular meetings with head teachers and with Hackney Education, and supporting them with training and guidance, and visits if necessary to support the work that they're doing in the schools. I don't know if that answers all of your question. And then the final question, sorry, you're going to have to remind me.
It was when will levels get to low
right,
enough
yeah.
that we can test, trace and isolate, we can stamp on it essentially?
Yeah, so that is a really good question. We've actually spent a lot of energy and invested quite a lot in developing our local contact tracing system. So we've got I wouldn't call it a lot of capacity, but we've built the capacity in that. So we started off with just a handful of people doing the work, and we've built on that capacity now. So we can also flex it. So if things got worse again, we'd be able to manage with higher numbers of cases. We still, of course, work with the national system. So it's not just a question of if they got low enough in Hackney, could we cope? It's about whether they got low enough so that we could, in London, because it's a test, an NHS test, trace and isolate, test and trace system set of people that works with London, they would have to be able to cope as well. And it's an unknown quantity, really, but I don't think that we have seen that number for quite a long time, and I think we probably won't see it for a few months. I think certainly our team can deal with tens of cases a day. We wouldn't really want them to, but they can in terms of contacting them and supporting them. What we haven't got, but we're working on, is a plan to support people to self-isolate, so that if we had to remove them, so suppose somebody lived in an HMO or a hostel or something, where they found it impossible to isolate effectively. So we're developing our support system for that, so we've actually got some kind of isolation facilities, as it were. But there are other support. There is other support that we probably need to put in place that causes, or the lack of causes, barriers for people self-isolating, like who's going to get my cat food, or I've got caring responsibilities, who's going to look after my mum who lives in another borough. And so some of that we can probably support people with locally, and some of it we probably need to work with other partners across London and possibly outside London to make sure it happens. And much of this has been escalated to government, who was asking for ideas about support, making self-isolation work better. And so we've told them all of this, and they're looking into what they can do at national level as well. But so it's a combination of things. Is when people are infected, either because they know that they are, because they've had a test, or because they've got relevant symptoms, or if they're a contact, they've been told they need to self-isolate. They need to do it, but in order to be able to do it, it's not that they don't want to, it's that they have to have everything in place. They have to have food at home, they have to know they can pay their bills, they have to have their caring responsibilities taken care of, they have to know they're not going to lose their job. All those things need to be in place, and so it's the isolate bit of test and trace that we really need to focus on now.
Dr. Husbands, thank you very much, as always, for your thoughtful and insightful observations on where we're at. I'm going to draw that item to a close. One thing that just occurred to me following on from Councillor Snell's question is obviously the way, the degree of which you've dissected the data as it's gone on has got more and more detailed, more and more impressive. The extent, perhaps, some of the way you've broken down in terms of the different ethnic community groups could be given to the vaccine steering group to adopt a similar approach to possibly inform policies, because clearly we're seeing it from the test and trace, but that sort of grid could possibly, I mean, no criticism, that sort of came and iteratively evolved, which is wonderful. But if that could be seen on the vaccine side as well, I think that would possibly help inform decision making and resources, possibly. But just an observation.
I'll pass that on. Thank you.
So with that, thank you very much. Now I'm going to move to item number 7. This is our first, believe it or not, cabinet question time with Cllr Kennedy. I'm not quite sure how it's taken us so long, but Cllr Kennedy, thank you very much. We sort of posed 3 sort of quite broad questions to you in terms of your reflections over the past year. 3 personal ambitions for your portfolio over the year ahead, and what do you regard as the biggest challenge in the next year, as why? So, Cllr Kennedy, over to you.
Thank you very much. Yes, I suspect in any normal time this would be my 2nd or my 3rd cabinet member questions, but of course it's not. And I suppose the first thing to say in terms of reflections for the past year is this was not what I was expecting when I took on the cabinet post for Member for Health for the London Borough of Hackney. But then, of course, our frontline health professionals were not expecting the year they've just had, and neither were all the other people who found themselves absolutely in the front line of this, having to carry on their jobs as shelf stackers or as rubbish collectors or as drivers. It's been an extraordinary year for everybody. I want specifically to talk about 2 things. I want to talk in terms of reflections for the past year. One is relationship between the government and local authority, and one is a reflection, a very personal reflection on mental health. But before I do that, there are a couple of quick things I noted down, which was I was astonished, and I remain astonished, by the extraordinary dedication and professionalism of our frontline healthcare workers. Every time I talk to them and see what they're doing, you've experienced it in countless meetings yourselves as members. You've just seen the way that you've been presented with the work that people are doing. It never ceases to amaze me, and I think we should always be praising and thanking those professionals for that work they do. I count LBH staff and officers in terms of being astonished by what I saw people do, the way they set up our response, the delivering parcels to our residents so quickly, the people who were redeployed. I also count the individual resident responses that I've seen in terms of the mutual aid groups that sprang up, the way people went out to clap for carers, the people who volunteered. You heard earlier about vaccine volunteers. 450 people are vaccine volunteers in Hackney. We have 150 community champions, more people volunteering all the time. Those responses have just been amazing. But given what was going on, it's a good job those responses were amazing. I mean, it was quite extraordinary, wasn't it? We had that, the first wave, the summer when we thought we might get a bit of a holiday, the second lockdown that didn't work, the cancelled Christmas. Now here we are in a 3rd lockdown. But right from when it started, I said I wanted to focus on 2 things: so government relationship with the council and mental health. I think my signature picture that sums up how the government sort of got it wrong and sort of stumbled in their response was those 3-litre plastic bottles of concentrated orange juice that they delivered in those first parcels when we were helping them deliver the parcels for the first fortnight. These were to our shielding residents, some of our frailest residents, and they were delivering something that many of them wouldn't even have been able to lift themselves. And one of the things that made us have to do as a local authority was a sort of signature moment for me, which was our chief exec and a group director with a corporate credit card going to a well-known supermarket in Stratford with a couple of shopping trolleys to make up for the inadequacy of government parcels. So a sort of a big government machine that couldn't quite do it, and then a local very fleet and agile and thinking on its feet response that I was very proud to witness and feel a part of. We seem to get it wrong at the government level so often. We talked about test and trace earlier. Right early on as a local authority, we've got that knowledge locally. why don't you let us use it, or at least use some of it? And there was a no, we're going to do it all response from government that was imposed from the top down. And actually, the government system went live, didn't it, towards the end of May. They didn't finally turn to us and say, oh, look, we'll hand you over the tricky cases until September. What a wasted opportunity. And actually, what really made the difference was local people who understood where people were living, calling and actually making up that bit where the government wasn't doing it. And we moved that success from 70% to 80%, 85%, using that local knowledge that should have been used so much earlier. And we set up the testing station at Sandford Court. Very delicate, a testing station very close to residents. Deloitte and Serco, 3 days before it was due to go in, said, oh, no, sorry, it's not going to be there for another month. Completely misunderstanding that we'd done careful comms. We'd sent the letters out to the residents. We said, sorry, it's going to happen on this day. Just not understanding any of the local stuff that was going on. You know, Chris Lovett had to go and I think have quite harsh conversations with them to get them to even understand those local sensibilities. We were finding out as a local authority what we had to do very often via the 5 p.m. announcement. So I think at one point there were no meetings at 5 o'clock because all officers and staff were glued to the telly. I think Polly Chook, Director of Comms, put it best. She said, well, I'm going to watch the briefing to find out what I've got to do tomorrow. That's how she found out what her priorities were, because it wasn't being shared in advance to give us the time to process that. And that's just a frustration I've got off my chest. The second thing I wanted to talk about in terms of personal reflection was mental health, and this is a quite considered personal reflection. When we had our first cabinet meeting, the mayor wanted to acknowledge people who died in the community. He read out a list of names of people who we'd known who died, especially healthcare professionals. You know, Dr. Charedi was on the list, and he broke down a bit, reading out the names of those people. And I thought at the time, I wonder if I could have done that. Did I understood why it had happened to him, and thought, well, I think I'm sort of coping with it. We had those Labour group meetings, you remember. Cabinet members used to have 3 minutes to do a quick update, and I used to have 3 minutes to tell you how many people had died in the last week and how many people had got COVID quite seriously and were in danger of dying, and how many people were in ICU. And I had to talk about our efforts to set up temporary mortuaries and things like that. And I thought I'd coped with that fairly well. And then got to September, asked to do a video for Wicker Ward, which is the big lottery scheme in my ward. And just talking to the officer there, and she said, you know, and how have you coped personally? I said, and I started talking about not having been able to hug my mum, and I just broke down in tears. And it wasn't something actually that I'd processed, I think, properly for myself. And I think actually, Chair, you and we were on a ward meeting, and I found myself finding it hard actually not to break down talking about Rabbi Pinter. Because I don't think I'd properly grieved for him and missed him, because he was someone I'd known. You know, I'd actually been to his house for some meetings when we were talking about the yeshivas when I was chair of a commission. And I think for all of us, there's been an effect on us by what we've gone through in the last year that we have to acknowledge, and acknowledge it's there for other people. Paul Kalaminas from ELF the other day on a call was talking about how the calls to CAMS have gone up 30%. So I just do absolutely want to highlight that we all need to be aware that what we've gone through in the last year was something very different, very strange for us. We're all used to understanding that we won't be 100% physically healthy, but I think we're very bad at not recognizing that none of us is ever actually 100% mentally healthy either. So let's acknowledge that and be prepared to work on it. And actually for counsellors, our mental health champion, Councillor Lynch, is actually arranging some mental health training for us as counsellors to help us both in our for ourselves, but also for our constituents, because I'm sure all of you will have noticed it talking to some of your perhaps more regular callers or people who contact you on a more regular basis. Certainly a couple of my constituents who have difficult relationships with their neighbours, for example, have not had a good year at all. And I need to know how to properly support them. So those are my sort of personal reflections. You asked me, my second question was about my 3 personal ambitions for the portfolio, and I've grouped those into 3 things. One I've titled Getting Out There, one I've entitled Nuts and Bolts of Adult Social Care, and one The Wider Health System. And getting out there is very much about looking forward to when we can actually get out there. I mean, I have talked to staff from our 4 care homes. I've reported the infection rates and the death rates in our 4 care homes on a regular basis, and I've checked them up every week in the gold updates. But I haven't been and visited and talked to people there and the staff there, and boy, am I looking forward to doing that in person, you know, with people and going to our housing. We've got 14 housing with care blocks across the borough. I'm so looking forward to just visiting those places and going to Oswald Street and meeting some of our residents and our staff there. I was lucky enough, privileged enough to compare the Care Worker of the Year awards online during the course of the year. That's something that normally is a tea party in the town hall, and you have tea and cakes with all the nominees. It is something that I've yet to experience in physically as a cabinet member, and I'm really looking forward to being able to do that. In terms of places and people, our own staff have changed a lot. Chair, I thoroughly join in your congratulations and your very warm and kind words that you said to David Maher and Denise D'Souza on this call, and I echo everything you said about them. And remember, as a system, we're losing Jane Milligan. We've got so you've got Henry Black as an interim, but will it be Henry who's in charge of the ICS? We'll have a new city and Hackney area lead to replace David. We've got a new group director, Helen Woodland. A couple of you on the call today were on her interview panel. I think she'll be a marvellous group director. Really looking forward to working with her. And Tim obviously has put in this new post director of integration, and I think that's going to be absolutely vital to one of the other things I want to talk about, which is the wider health system and how all that fits in together. And I don't think I'm allowed to tell you who we've appointed to Director of Adult Social Care, but we have a great new Director of Adult Social Care coming in as well. My second point under this item was what I put down as understanding the nuts and bolts of adult social care and its funding, and it's pitifully made up the way that social care is funded. You've got the Integrated Better Care Fund, the Winter Pressures money, and the Social Care Grant, which are basically top-ups that are. You never know from year to year how much they're going to be, or indeed even whether they're going to exist still, and basically is an admission that government has never really got it right. And somewhere coming down the line, I hope there will be some sort of DILNOT-based funding change that will actually work properly for us. The Association of Directors of Adult Social Care reckon across the country we're £4.5 billion short of what we really need to provide proper social care going into that local authority section of budgets. You know, the Health and Care White Paper is silent on that, apart from to say we promise we'll sort it out further down the line. It's possible, given how much, you know, if you can turf out 12.5 billion in PPE contracts to people who don't know what they're doing with PPE, you know, maybe you can find something for adult social care. Sorry, that's slightly flippant. Obviously, that was a one-off, and this would be a vast increase in funding, but it would be lovely to get involved in the nuts and bolts of that. And I don't still properly understand how that all works at a local level, except that it's a lot of money, and that being allowed to increase the adult social care precept from 2% to 3% in our council tax bill doesn't even cover the inflationary uplift that we have, just to set down how those pressures work. So I've now got monthly meetings with Naeem Ahmed in my diary to actually properly understand how those things work, and we've got recommissioning of housing with care, home care, and telecare coming up, and at least in telecare, I'm hoping that we'll be able to insource some of that, if not all of it. That's obviously still being worked on. My final point under this is, why do we only have 4 care homes? Shouldn't we have more than that? We have relatively low number of care homes for a borough of this size, and I think if there's an ambition project under places, it's the median road building and what we might be able to get out of that, which is something I look forward to considering. So I realise I've jumped straight from my places and people into nuts. Oh no, I told you I was going to do nuts and bolts. That was my second one. My third point under this is NEL. The wider health system, NEL, the integrated care system. What is that? That final NHS body that sits at the top of NEL going to look like, and how can we influence it? I think we can influence it. This isn't a white paper that actually asks for comments, which they normally do. That isn't going to stop us making comments. I've already had conversation with Sandra about this, and we've agreed that we will be making some comments, but you know, I'll be linking with partners across the piece to look at this. I think the most positive thing to say about it is it doesn't look particularly prescriptive. It doesn't look massively set down in stone, and it does talk about areas being able to shape how things work best for them. In a way, we've already done that. The amazing work that you quite rightly praised David for in terms of City and Hackney CCG was so good and had formed such a solid centre for our footprint that we managed to preserve it as one of the 3 area-based settings that sit underneath the ICS. And if we can build on that promise that that amount that Henry Black has made, that same amount of funding will come down to that level and be spent in that level, and that it won't go down, then we've got a solid working point to start from. You look at some of the things that happened during the pandemic. The discharge work was amazing. I was working through the SOCG in partnership with the wider health system, worked really well. It proves that we can integrate. We can work in an integrated way. One of the things the white paper does hint at is putting the Integrated Better Care Fund on a more solid footing, provided you're providing integrated services, both the local authority and the health system working together. I think that's probably a good thing. But the core of it, and the core of where it will all be delivered, is at that PCN level. Jane Milligan said it's the PCN level, the neighbourhood level, where real change will happen. When she was talking about, someone said it's just a reorganisation, nothing will actually happen. She said the real change will happen there. So if we get the multidisciplinary teams right, the community coordinators, the social prescribers right, that's where we actually can, I think, really make a difference. But it builds into my answer to your question 3 of what the biggest challenge is over the next year and why, and that is overcoming health inequalities across our communities and between our communities. I think that neighbourhoods is where we can overcome those and have the ability and the opportunity to overcome them. But I didn't realise Peter Merrifield was going to be on the call tonight, but I did write down a quote from him from the Black Communities Vaccine Information event on Thursday, where he made a very passionate and simple appeal, which was not to let the people who had been disproportionately affected by COVID to become the people who were disproportionately affected by being under-vaccinated. And it also links back to the state we were in before COVID, because remember, COVID acted as a sort of magnifying glass to the health inequalities that were there before. I've been really heartened this week to see Michael Marmot out and about, talking again about the wider determinants of health, the work that he'd done before. It was wonderful to hear him battling with Melanie Phillips on the moral maze, if any of you get the chance to listen to that Radio 4 programme. But that challenge that we knew was there before about health inequalities across the system got magnified, and it's up to us now using the tools that we have at our disposal at a local level. And by that I'm talking about that where at the Health and Wellbeing Board we've decided to adopt the King's Fund population health model that looks at those intersectionalities between the wider determinants of health behaviours and lifestyles, integrated health and care systems, and the places and communities we live in, and where those 4 pillars meet is where you can influence and effect the most change. Sandra quite rightly has set up a health inequalities steering group that is going to look at ways of measuring change and how we can satisfy ourselves that we're doing the right thing. That's a subcommittee of the Health and Wellbeing Board, and will provide those assurances for us. I think with that inequality steering group in place, as we write our new health and wellbeing strategy, keeping in mind that overcoming inequality is absolutely our driver, and also that it can't happen in a vacuum, but it happens in the wider system with those wider determinants that I've talked about, then we actually stand a chance, I think, of really making a dent in that. But that's our biggest challenge. And why is it our biggest challenge? It is because it has been for years, probably decades, probably since the NHS was set up. It's never quite really done what it wanted to do in terms of ironing those out. But COVID can be a springboard and a source of hope, I think, for being able to change that. The final thing I wanted to say was I went today on a quick visit to the Pembury Hotel, which is the hotel where we have everybody in our homeless residents staying, and I spoke to a young man called Alex who'd been vaccinated today, who's homeless, and he was absolutely delighted, and it was a source of pleasure and pride to him, and something that was sending him out in his life with hope. And the health system can do that. And we are talking about health in all policies when we talk at the Health and Wellbeing Board. I will stop there, say thanks for the opportunity, because I realise you've got a minute left to do the rest of your business. And I will say to members of the Commission, when I do my updates at Labour groups, sometimes I get chased down the chat bar with questions. It doesn't need to just happen at Labour group. You can always ask me a question. I'm always happy, especially from members of the Commission, to answer questions and queries. Thank you, Chair.
Thank you, Councillor Kennedy, for your moving, thought-provoking and insightful comments. I'm not going to take questions because of the hour. But before I wrap up business, I think it's probably only fitting that we just go to David Maher. David, thanks very much for your work over the last few years. Any parting remarks, and also who's going to be the new David? Do we know?
Well, I think if anything, Chris's kind of summary of his own experiences during COVID is a kind of one of the reasons that I guess what makes Hackney so special is the humanity and the decency and the kindness of people, which I think Chris just really well summarised. So yeah, I shall miss the place deeply, and I thank you for all your support over the years. It's been an amazing experience working here with such committed people, and with the culture that we've built here, that culture of cooperation, collaboration, support, just wanting to get the best for each other and for our people. So I think that's what makes City and Hackney, and it's what will make the next chapter equally successful as the previous one, is that culture of collaboration. So I'm looking to ask one of my senior, well, we're going through a process with one of the senior team to take on some additional responsibilities over the next kind of week, 2 weeks. We're doing a kind of an internal mini process. They will work with Tracy Fletcher as the Integrated Care Partnership Lead for City and Hackney. Jane Milligan's written to her to ask her to take on that leadership role. Tracy will convene the Neighbourhood Health and Care Board, which will sit alongside the board that Chris chairs, the Integrated Care Partnership Board, along with Mark and Randall. They will be getting on with doing delivery and bringing all of that passion that Chris described to light, really, through our work programme. So I just want to say thank to you for all you've supported me with, and your patience and your kindness. Yeah.
Thank you, David, and all the best. All the best in your new role. So thank you very much. I see there was a question from Councillor Snell. I think Councillor Kennedy can take that offline. So then, just wrapping up the meeting then, the minutes, can I take them as agreed, please, members? Thank you. Thank you, Denise, for sharing the quality assurance framework with respect to care homes. I think Jarlath has or will forward that on. Work programme, as always, I think certain items have come out today in terms of an update on vaccine concerns or hesitancy, and I think Councillor Kennedy has just raised a number of matters that we could continue to look into in the short to medium term. I haven't been notified of any other business, and so with that, I'll close the meeting, and thank you to all. Thank you very much.